Hello, my dear friends. Welcome to the today's daily dose. I am myself Dr. Rajesh Gubba. I am a cardiologist and I am also the mentor for teaching general medicine in exams like NEET PG, PGA, JIPMER, and as well as AIMS. So, as the part of today's daily dose, the clinical question is I have a 57-year-old male admitted with complaining of headache and as well as blurring of vision, and his blood pressure is 240 by 150 millimeters of mercury, and he has bilateral papilledema, and he is fully oriented and as well as conscious, and he has been known to be hypertensive for about 5 years, and his blood pressure control has been good on 3 drugs. However, he had decided to stop all medication 2 months before this event. Which of the following would be your preferred parenteral medication at this point? Options are glyceryl trinitrate, hydralazine, labetalol, sodium nitroprusside, and phentolamine. So this particular question is the management of the accelerated hypertension, right? So you see the blood pressure is 240 by 150. Now this we consider it as accelerated hypertension if the blood pressure of the individual is more than 180 by more than 120 millimeters of mercury, right? And this accelerated hypertension, we can classify it into hypertensive urgency and then hypertensive emergency. Now what is the difference between these two? So if you take hypertensive urgency, there is no end organ damage. Whereas in case of hypertensive emergency, there is presence of end organ damage in the form of cerebrovascular accident or hypertensive heart failure or hypertensive nephropathy. That is what is your hypertensive emergency. Now this particular individual, his blood pressure is 240 by 150 and he is having bilateral papilledema, that is swelling of your optic disc. And he is having headache. Why is that? That is because of the accelerated hypertension, and there is also blurring of vision. So as such, the end organ damage is not very specific in this particular individual. So now which is the preferred drug? Now previously, let me tell you, like we were using sodium nitroprusside for accelerated hypertension. But the problem with the sodium nitroprusside is that it will cause rapid fall in the blood pressure, resulting in cerebral hypoperfusion, where the individual may land up in the collapse. And very strict monitoring of the blood pressure is very much required when the patient is on this sodium nitroprusside, right? And also because of its adverse effects, nowadays the sodium prusside is no more used as the first line drug. And what is the next immediate line of management if we are not having or if we are not using the sodium nitroprusside? The other important drug for accelerated hypertension is your nitrates, that is glyceryl trinitrate. So glyceryl trinitrate has many advantages. Number one, it can reduce the preload. Number two, it can also reduce the afterload on the heart. That is the advantage of your glyceryl trinitrate. But what I will do is, I will tell you, depending upon the end organ damage, what is the preferred antihypertensive that we need to use. Let me discuss on this point. So for example, if the individual is developing the ischemic stroke in a scenario of hypertensive emergency, the drug of choice is nicardipine, and the drug that need to be avoided is nitroprusside. And for example, if the individual is developing myocardial ischemia and infarction in a clinical scenario of hypertensive emergency, the drug of choice is nicardipine, which is a calcium channel blocker, and esmolol, which is a beta blocker. Whereas you take in a clinical scenario of aortic dissection, then the drug of choice is the beta blocker plus calcium channel blocker, that is nicardipine. Whereas you take in a clinical scenario of acute pulmonary edema due to systolic dysfunction, there we need to give a diuretic. Why? Because there is a lot of fluid in the lungs, so that has to be completely drained out, so we need to give the loop diuretics. And along with that, you need to give a drug which will reduce the preload on the heart, that is your nitrate. And as well as the other important drug that need to be given is nicardipine. So the recommended drug in acute pulmonary edema due to systolic dysfunction is nicardipine, nitroglycerin plus loop diuretics. And the drugs that need to be avoided is the hydralazine and as well as beta blocker. So beta blocker is avoided because the individual is having systolic dysfunction and the individual is in a state of decompensated heart failure. So in a patient with a decompensated heart failure, beta blockers are completely avoided. Next, you take it in a clinical scenario of acute pulmonary edema due to diastolic dysfunction. So here we need to give the beta blockers, that is esmolol, nitroglycerin and as well as loop diuretic. Now you see the point here. If the individual is having pulmonary edema due to systolic dysfunction, beta blockers are avoided. But if the individual is having acute pulmonary edema due to diastolic dysfunction, then in such scenario you can give beta blockers. Whereas if the individual is developing acute kidney injury, the drug of choice in patients with hypertensive emergency is your phenoldiazepine. And what I have said you about the sodium nitroprusside. Sodium nitroprusside is no longer the treatment of choice in case of hypertensive emergency because of rapid fall of the blood pressure by the sodium nitroprusside. Next, you take the other options, right? So the preferred drug is your glyceryl trinitrate, whereas you take hydralazine, which is an arteriolar vasodilator, labetalol, which is an alpha blocker. These two drugs also can be given, but these are less reliable compared to that of your glyceryl trinitrate. Then what about your phentolamine? Phentolamine, it is also an alpha blocker, but where do we give this particular phentolamine is that, so in a clinical scenario of the pheochromocytoma, we give this particular phentolamine. So in case of the pheochromocytoma, we give alpha blockers and followed by that we give beta blocker. Or in pheochromocytoma, you can give both alpha plus beta blocker, that is labetalol can also be given. But in pheochromocytoma, the treatment of choice is surgical resection of the adrenal medullary tumor. But before doing surgical resection, you have to maintain the blood pressure around 160 by 100 millimeters of mercury. Now, in order to maintain the blood pressure around 160 by 100 millimeters of mercury, then we need to use this particular phentolamine. So, preoperatively, we need to put the patient on phentolamine to reduce the blood pressure. And once the blood pressure is reached less than 160 by 100, then you can take the patient with the surgical resection of the tumor. So overall, in nutshell, in this particular question, the preferred medication is glyceryl trinitrate. And remember, sodium nitroprusside is no more used in this particular situation. So thank you very much. So this is about the today's daily dose. And please follow our channel for the daily updates. Thank you very much.